My name is Priya Kishnani. I'm a clinical and biochemical geneticist, and I am at Duke University Medical Center, where we run a large program for patients with rare diseases, but especially with a focus on lysosomal and glycogen storage diseases. This has been a very exciting conference, and the ability to share some of our data. So the first I would like to talk about is use of a very novel way to measure ptosis in children with infantile onset Pompe disease, and this was as they were switched from alpha-glucosidase alpha to alpha-glucosidase alpha. Of course, as a disclaimer, alpha-glucosidase alpha is not approved in the US for children with IOPD. Yet I think the learnings from here have been very critical, that we've got to think outside the box in terms of trial outcomes and how to evaluate our patients with rare diseases. And so I'm using Pompe as an example. And here we were able to quantitatively measure ptosis before the patients switched to alpha-glucosidase alpha, and then very nice improvements by just these kids wearing fun eyeglasses, but with a measuring tape, which allowed us to assess that this was a domain that was improving, which would have otherwise never been captured on traditional measures that we tend to use. The other thing that I would love to talk about is the real world experience now in patients who are switching from standard of care alpha-glucosidase alpha to alpha-glucosidase alpha. I think the boundaries of a clinical trial kind of boxes us into the inclusion criteria. And if you think about COMET, it was patients who were naive to enzyme therapy and were then subsequently switched or started on alpha-glucosidase alpha. I think these are some wonderful data from the registry, and so it captures a wide range of patients in terms of how they have presented, and also they have been exposed to standard of care alpha-glucosidase alpha. And so we are now starting to see first of all, what's the profile of the patients that are switching, and the second is how are they performing after the switch to alpha-glucosidase alpha. And so in the registry there are more standardized measures that are used, such as the 6-minute walk test and the forced vital capacity as a percent predicted in the upright position, and then looking at biomarkers. So I think this is just the initial phase, but there will be more to come. In simple lay terms, it is a drooping of the eyelid, and this is due to muscle weakness, and has also been found to be a part of the clinical spectrum of Pompe disease, and thus showing improvements not just in big skeletal muscle groups as evaluated by the 6-minute walk test, but also looking at other impacts such as in eyelid muscles, which results in a drooping of the eyelid, which can also impact quality of life, activities of daily living, and for children even as they are in school, being able to see better. Just because the eyelid is now where it needs to be is an important aspect of the disease that should not be overlooked. The way I look at it is for practitioners to recognize that there are now 2 next generation enzyme therapies that are available, which have improved targeting capabilities to the skeletal muscle because of more mannose-6 phosphate, or I should say bis-mannose-6 phosphate, to allow for better targeting to the receptors on skeletal muscle. And as such, I think there needs to be a thinking about how to bring this information to patients. First of all, those who are currently on alpha-glucosidase alpha, but next also as new patients are diagnosed, of giving this information and providing not just the clinical trial data, but now also real world evidence of what we are learning about when one switches to these next generation therapies. So for the study evaluating Ptosis, it was actually very good to see that patients who were enrolled in the study needed to either be clinical decliners or those who had a suboptimal response to standard of care enzyme therapy. Some of them were on doses of 40 milligrams per kilogram per week of alpha-glucosidase alpha, so which is 4 times the labeled dose, and was still experiencing either a suboptimal or a clinical decline. And it was very gratifying to see that you had improvements in something like Ptosis, which is so meaningful in everyday life. And these were patients who had now been switched to 40 milligrams per kilogram every 2 weeks of alpha-glucosidase alpha. Of course, again, the caveat is this is a small group of patients, but it's kind of encouraging from a data perspective, but also from a real world perspective of trying to adapt such kinds of measures in a busy clinic to try and capture change.